I think we'll actually get started with our program. We have a number of attendees on with us. So again, good evening, good afternoon, good morning, wherever you are dialing in from around the world. I know we do have some international attendees that were joining us as well. Thank you so much for taking the time to be here with us this evening for this clinical roundtable discussion, Changing the Dynamics in Wound Healing with Phoenix Wound Matrix. My name is Beth Joy Doherty. I'm the Vice President of Marketing with Renovoderm, and I'm very pleased to be here for our second clinical roundtable to really bring forth and have you understand and hear clinical perspectives on utilizing Phoenix Wound Matrix for wound healing. As a regulatory statement, the purpose of this clinical roundtable is truly to allow for peer-to-peer discussion and the sharing of information and observations as a result of using Phoenix Wound Matrix for wound healing and tissue repair. The information and observations shared in this clinical roundtable are based on the individual's clinical judgment and as presented in the documented cases and photos with patient consent for the healthcare professional. Renovoderm does not promote the use of off-label utilization of Phoenix Wound Matrix. And as always, please make sure when using a product to refer to the instructions for use. I am very honored and pleased to announce the presenters on our clinical roundtable. Our moderator for today's program is Frank Aviles. Frank is a wound care service line director for Natchitoches Regional Medical Center, overseeing and assisting with wound care practices across the continuum of care. In 2015, as part of a team effort, he was instrumental in the successful startup of the award-winning wound care program and leads an inpatient multidisciplinary group to eliminate hospital-acquired pressure injuries at NRMC with proven success. Frank's career began with a passion for wound care about 30 years ago. He's a global innovator and educator with a driving goal of educating others to help improve wound care best practices and patient outcomes. His love for his profession has led him to teach all levels of medical discipline at the academic, national, and international level. In 2008, he originated and continues to host many multidisciplinary wound healing roundtables to help educate and foster a community of care approach for wound healing. And of course, when he saw that there was a need to not have a negative impact on education during the COVID-19 crisis, Frank quickly learned and started live virtual rounds to continue that clinical rationale and education for students and peers alike. In addition to all of these daily duties, Frank is also on the board of the APWCA and a wound care consultant for the Louisiana Extended Care Hospital at Natchitoches and LHC Group, and is a wound care lymphedema instructor and advisor for the Academy of Lymphatic Studies and an educator on lymphedema and therapy. Also, as part of our panel, Dr. Mark Moline is a surgeon and medical director of the M Health Wound Healing Institute and an adjunct associate professor in the University of Minnesota Surgical Department. Dr. Moline is a graduate of the University of Minnesota Medical School and completed his general surgery residency and vascular fellowship at the Mayo Clinic in Rochester, Minnesota. His interests and educational niches include management of lymphedema in the wounded patient, the endothelial glaxocalyx, adjunctive micronutrient application to wound care, micronized purified flavonoid fractions, wound pH and biofilm management, and emerging technologies in wound care products and wound care technologies. He participates in the educational activities of the surgical department resident training program and resides in the suburbs of Minneapolis with his wife of 31 years, Cindy, where they also have 4 grown children and rescue dogs. In his spare time and what he just shared with us, he likes to camp in the Boundary Water Canoe region of northern Minnesota, and also is a baking enthusiast of artisanal breads and reading. On to Dr. Sarah Morrison, who is originally from Chambersburg, Pennsylvania, and attended Villanova University on a scholarship for track and cross country. She was first introduced to podiatry working as a medical assistant in an office on the main line and quickly grew to learn and love podiatry. Dr. Morrison attended Temple University Podiatric Medicine, School of Medicine in Philadelphia, and later did her 3-year residency with Bryn Mawr Hospital and the Mainline Health System. Dr. Morrison was rear foot and forefoot surgically trained and was exposed to a high volume of wound care throughout her residency. She was hired as an attending in a local private practice with affiliations to the Mainline Health System and deal with a tremendous amount of inpatient and outpatient wound care needs, including being on staff at the Riddle Hospital Wound Healing Center. And finally, Dr. Mike Regan is a hospital-based limb salvage and reconstructive surgeon and podiatric surgery department chairman at Miami Valley Premier Hospital and Kettering Dayton Wound Center, limb salvage service in Dayton, Ohio. He has dedicated his practice to limb salvage and reconstruction as a surgical hospitalist since 2007. Dr. Regan took his Bachelor of Science degree from the University of Scranton in 1979 and graduated from the Kent State University College of Podiatric Medicine in 1983. He completed the Green Memorial Hospital Podiatric Surgery Residency in 1985, based at St. Elizabeth's and Green Memorial Hospitals in Dayton, Ohio, with a heavy concentration in plastics and orthopedics, and is a board-certified diplomat of the American Board of Foot and Ankle Surgery. Dr. Regan began a private practice in 1985 with a dedication to limb salvage and reconstructive surgery. And in 1990, he founded the Jewish Hospital Kenwood Podiatric Foot and Ankle Surgery Residency and remained a division director and teaching service director until 2007. As a passion, Dr. Regan continues to be active in teaching medical and surgical residency programs, research, and providing presentations for the advancement of medical education and limb salvage to local, national, and international organizations. It is my distinct honor to welcome all of you, our panel here this evening. Thank you so much for your time. Not only in developing the clinical roundtable with me, but certainly your time that you have taken working with Phoenix Wound Matrix. And I'm so much looking forward to this discussion and you sharing your outcomes. Just a little bit about Renovaderm and Phoenix Wound Matrix. Renovaderm is a regenerative medicine company, and we do focus on the manufacture and development of a new category of technology, especially within the wound healing market, 3D engineered electrospun synthetic polymer technology that truly is helping to improve clinical practice, improve patient outcomes, and a goal to reduce the overall cost of care. Specifically with Phoenix Wound Matrix, our mission is to help change the dynamics in wound healing and make a profound impact, not only on the clinical, but as well as the economic burden that we do face in healthcare with helping to heal wounds. As we go through the presentation, Frank is going to moderate and will be able to engage and share his own clinical practice as well in utilizing Phoenix Wound Matrix. So Frank, with that, I'm going to turn it over to you so that you can share a little bit about your early observations and outcomes with Phoenix Wound Matrix.
So first of all, Beth, thank you for the introduction. I didn't know if that was me you were introducing, but I want to tell you that I'm very passionate about what I do. And the patients that I help, and I have 10 doctors that I help in our clinic, and my job is to help those patients that are falling outside the outlier rate. And what we do is we deal with inflammation. So for 31 years of my career, I spent time trying to get patients out of that inflammatory stage. So to tell you a little bit more about my experience with Phoenix, a while back in 2017, I was approached by somebody by your liaison, and I gave them advice. I wanted to let them know that, you know, if you can change the inflammatory phase, then you got a great product. shortly after that, I was asked to come to the home office and educate the developer and the team on regular wound care. And I was so fascinated because when I heard about the technology, and actually the technology came also, they were using it in arterial surgeries where they can repair vessels. So if anything can repair a vessel, then in a wound, it should be a great product. And that's what piqued my interest. And when I came back to the clinic, I started using the product and I was amazed by the results. Now, for everybody listening, I do have to tell you, I'm not a salesman and I'm here to talk about chronicity and wounds. So when I started using the product, I did learn that this is a synthetic product. It's a product that can change the wound environment. So now you're taking a wound that's in the chronicity stage and you can actually build up a foundation. Your extracellular matrix now has the ability to sustain cells to come and do their job. So it all sounded great. And keep in mind, I'm not a researcher, but I like that because I learned from my peers and from people on this panel that everything happens at the cellular level. And so I sort of started looking into it in the early phases. I kept saying the wound bed is changing, find out why. And there was a lot of research done, and we knew that we changed the pH. So what else can it do? And lactic acid, hydroxide acid, and fatty acid were also helping to change the barrier. But either way, what we were looking at is we were looking at a product that was beginning to change the environment. And I was skeptical at first, but as we go, I'm going to show you my first cases that I saw. So I do want to tell you, again, thank you for letting me be part of this panel and moderating this. I did moderate the first one a few years ago, and it was phenomenal information. But I wanted to highlight this chart that you have. And when we talk about chronic wounds, we all know that addressing that chronicity is what's going to help us. And the patients that are coming into our clinics are sicker. They have more comorbidities, they have more problems. And even though we're supposed to do the right thing, evidence-based practice, we're also doing insurance-based practice where the insurance is saying, no, you can't use that one. So you got to come up with another product. But if you look at that chart, I can see this product helping with the inflammation where you can lead into another product to get it to the closing phase, or sometimes it may not have the need to use another product. So again, every clinician is different. There's a lot of opinions, but now I was seeing where we can alter the environment. Next slide. So this is a compendium, and I know a lot of these were early on from my cases, but I loved when I saw the cases that we're going to share from the panel, I was excited. But I can tell you that we tried it on everything, and most studies kind of select patients. The way we selected patient was, these are our outliers, nothing's working, they're facing amputation, let's just try it, it can't hurt. And actually, I tried it in one of the units, and my role spans over the whole continuum of care. So I had a little kind of competition with the wound care clinic. So when they went to another setting, I was trying to say, I can do better than y'all. But what we did is we tried Phoenix on a patient, and this patient that was not healing beforehand ended up going back to the outpatient clinic, and everybody kept asking, what did you do? So once I told them, we started trialing it on patients that were our outliers. So we tried it on the worst of the worst cases. So next slide. And so these were some, and actually the one you see on the far left, we tried on necrotizing fasciitis, and we saw how it changed the wound environment. The granulation tissue looked different. It was like regular granulation tissue, but on steroids, not as far as size, but as far as being potent and red and ready to move on. And then the second slide was the first patient I've ever put this on. And what I saw kind of caught my eye. And again, I didn't believe it. So we tried it on other patients, but within days, we were seeing that granulation tissue we didn't get with months before prior treatment. And then, of course, the other case, that belongs to another clinician that used your product, and that was a vascular issue, and they were getting actually healthier tissue with it. So what we saw was something that could change the game. Next slide. So now I do want to introduce, I have the most respect for Dr. Moline. Dr. Moline has a very busy practice. He's not only a wound care physician, but he's a vascular surgeon and lymphatic extraordinaire. Every time I listen to Dr. Moline, I learn something, and I want to tell you that we're going to learn about him and his product usage. So Dr. Moline.
Thank you, Frank. Yeah, very complimentary. You know, I stopped doing vascular surgery about 4 years ago to focus purely on complex wounds, and I've been involved in wound care for about 22 years in a organized wound clinic fashion. So, thank you for your introduction. I want to thank you both for the opportunity to participate, and it's really a great opportunity to be beside the other two panelists and their expertise. I want to put all this within the scope of what's standard of care. So I don't think we can escape the fact that when we're talking about new technologies, like Frank said, we usually apply it to the most difficult, challenging cases that enter our clinics, and where a myriad of other things have been applied without resolution. And so I think when we look at these patients, it's always important to go back to basics. And so addressing things like tobacco use, diabetes care, hemoglobin A1C, offloading. In our clinic, total contact casting is the standard of care for application for plantar surface, and making sure there's adequate arterial blood flow. So getting ABIs, we do a lot of correlating duplex ultrasounds. Venous insufficiency evaluations to look for management of superficial venous insufficiency and management of venous hypertension. And then the one that tends to be overlooked, especially in lower extremities, is really near to Frank's heart, is lymphedema. And there's that phrase out there called phlebolymphodema, and we know that patients that come in with venous hypertension, 100% of them will have associated lymphedema that I think is under-recognized, under-treated. So I just want to put within the scope of care when these patients come in here and we're looking at products like Phoenix, it's with the understanding that we're doing all these other things first. And then the other thing that's near and dear to my heart is micronutrients. So are we doing things that maximize endothelial cell functionality? And it's recoupling nitric oxide production, which helps with immune system function, as well as maximizing arterial dilation and lymphatic function. So this is first case is the top of the skull. So this is a gentleman that had a radiated field after melanoma resection, recurrence, repeat Mohs, skin grafting, and then ended up with bone exposure. Now we had used other products just to get to this point. At one point it was probably a $50 size worth of bone exposure. So of course, MRI, make sure there's not significant underlying osteo. I took him to the operating room. We took care of the bone. We did ultrasonic debridement and really good wound bed prep principles. Now the middle three pictures look a little bit odd, and that's because we were using fluorescence imaging, so molecular imaging, to look for critical colonization, which would be defined as greater than 10 to the 4th colony forming units. Because that's the other thing, is you have significant biofilm, it can be difficult to get these wounds managed. So we know from peer-reviewed published data that most chronic wounds have a pH of 7.15 to 9. Skin mantle pH is 5.5. So this is what was one of the things that really attracted me to this product, besides my conversations with Frank and his clinical expertise and experience, was this unique ability to take a product that could very durable, very easy to handle, easy to apply, well tolerated by patients, and has this ability to lower wound pH as it's interacting with the wound. So as we decrease wound pHs below 6 and back down to that acid mantle of 5.5, this is where we see a shift in the wound environment, decreasing that inflammation, and then maximizing angiogenesis through the resolution of inflammation and the resolution of the inflammatory components of high bacterial loads. So in the molecular images you see, we also can pick up on exposed bone. We can pick up on Pseudomonas if there's a signing. The red or the proveridins will tell you about strep staph and various other microbial elements. So this is just showing us cutting this up. Very easy to cut this product, very easy to apply it, very easy to secure it. And durability, in addition to versatility, is the other really significant component. So we can put this on, and we would bring the patient back in during our initial trial every week to look at it. And oftentimes this product would be on for 2 weeks, if not a little bit longer than that. So the durability in terms of release of the product, I think, is really important and was helpful in this case. Next slide, please, Beth. Now, this is obviously a heel. This is a right leg. Again, standard of care would be application of total contact cast after ensuring that there's adequate arterial blood perfusion. And then in a diabetic like this, of course, that oftentimes has associated neuropathy, making sure we have really good cast application so we don't end up with secondary ulceration. So again, here are the markers. You can see in that second frame, that red is Perviridins, which shows that we've got to do a better job of wound bed prep. So it allows us to do really good targeted application. But again, significant biofilm in this, even though it looks to the eye like it's pretty well prepped. So the thing I love about in this application is the durability of the product, knowing that we're going to get consistent driving down the wound pH and moderation of the inflammatory components inside of a total contact cast environment. And so to be able to then take the total contact cast off after a week and know that we're getting good moderation that entire week. So we're getting good offloading plus good wound bed management of that inflammatory component. I think this is would be a fascinating study to take. And this is something I'm going to ask Mike about as we're doing our Q&A, but taking a large, you could do it as a randomized controlled, you could do it as a retrospective, but looking at how does this function under total contact cast, and this could be a real accelerator for DFUs on the plantar surface. Next case, please. And then this is another complex case. So obviously we were using this in the toughest of the toughest. So this patient had a 5th metatarsal osteomyelitis. He's a kidney pancreas transplant, immunosuppressed, severe obesity, and there you can see a little bit of heme or blood running down after we had debrided based on the moleculite imaging. So, but the fascinating thing around this, if you look at actually what's going around the wound, all that cyanine outside of the wound is all Pseudomonas and hyperkeratotic tissue. So the other thing that moleculite taught us was we got to treat the entire, not just the wound bed, but treat the entire foot. Get rid of all that hyperkeratotic tissue goes back to maximizing wound bed application. So here we have a markedly immunocompromised patient, diabetic, difficult, even though with his pancreas transplant, he's still having a little bit difficult controlling his numbers. And the durability to be able to put a total contact cast on in this point again and to be able to use it. Easy to apply, long durability, and versatility, and we get good outcomes in very, very difficult cases. So Frank, with that, I think that's my last case, if I recall correctly.
Yes.
Thank you, Beth.
Yes, and Dr. Mullane, I'm going to save some of the questions for later because I'm sure everybody's interested in seeing all the case studies that are coming in. But anyway, now I'm going to introduce Dr. Sarah Morrison. Again, she's from Pennsylvania, podiatry surgeon, specializes in the foot, like Beth said. And Dr. Morrison, if you can take us through your patients through the slides, that'll be wonderful. And thank you for being here.
Absolutely. Yeah. Thank you so much for moderating. And Beth, thank you so much for inviting me on the panel. I feel kind of like the new girl on the block with a lot less letters at the end of my name, but going to give it a good go. I was contacted by a rep with Renovaderm who works under Beth right about the same time that I met my patient, actually, about a month later. And so it was this weird coincidence, and the case study I have, the patient has pyoderma gangrenosum, so it was, you know, a little bit difficult in general treatment-wise for curing his wounds, but you know, I trialed actually 2 different topical therapies and thought that the Renovaderm graft might be a good shot to throw in the mix to see how it did. And so I'll kind of walk everybody through that. So I met the patient actually in the hospital after he had been diagnosed with pyoderma. He had had a wound, as you can see, very, very large, nearly completely circumferential, that had been initially started as just a little scratch on the back of his leg. He had had treatments by a dermatologist at Jefferson University downtown in Philadelphia prior to me meeting him, who did a wound tissue biopsy, which ultimately was, relatively benign, other than the typical increased neutrophilic rates, ulcerative tissue, necrotic tissue found in typical pyoderma biopsies. He had come into the hospital for cellulitis and increased pain from the leg. As you can see, the wound itself looks a little bit daunting for those who don't know exactly what pyoderma is or who don't deal with wounds typically, but he is a overall very complicated patient, relatively uncontrolled type 2 diabetes, obese, PAD, PBD, edema bilaterally, which was relatively uncontrolled secondary to neuropathic pain. And then ultimately, actually in the beginning of June, he had an NSTEMI. So it kind of complicated all kinds of things for me, treating him consistently. But ultimately, when I had met him, was on a high dose of oral prednisone, which the dermatologist was managing. He was trialed to go on a taper of prednisone and was hoping to get over to more of an IV infusion therapy with Remicade. The outpatient visits, I followed him from the beginning of March, like March 1st of this year through the end of this month. I had been seeing him weekly and tried to stick to, from what I understood, for good treatments of pyoderma, topical steroid, topical Santyl, collagenase, and then as you'll see moving forward later on with the pictures, I separated out an area to trial out the Phoenix Renovaderm graft in combination with the Santyl in other areas to see how they kind of compared in terms of treating the wound, to see if I could get them at least stable or healed ultimately. So just a little background for those of us on the conversation. Pyoderma itself is a little bit complicated and different than most lower extremity wounds. It is 50-50 related to underlying systemic disease. A lot of times people present with Crohn's or ulcerative colitis and systemic inflammatory disease, sometimes hematologic cancers. It is a neutrophilic mediated issue where the skin and wounds get this increased neutrophilic presence that have a characteristic purple overhanging edge. The treatment ultimately, a lot of people, what I actually saw as a resident, if you don't know exactly what pyoderma is, you would think, oh, well, let's take this patient to the OR, we need to debride it. It actually is incredibly harmful to do that and leads to further expansion and prolonged course of the wound. So the mainstay of treatment ultimately is either underlying systemic disease therapy or ultimately high dose steroids. And recently people have started to kind of trial out new immunologic or modulating agents such as sulfasalazine, cyclosporine, and even IV infusions of Remicade, Enbrel, and Humira. So here are a couple pictures. Beth kind of lined up for me, which was awesome. The circles are the areas of where I had applied the Phoenix graft. I think, as Dr. Moline was kind of saying, the durability of the graft itself was actually very surprising to me. You open up this package and it's like you got a little sheet of paper. And so the paper lays on very well, secure it with steri strips and some gauze. The outer portions of the wound, other than where I was applying the graft, I utilized Santyl. That was ideally, hopefully, going to debride and get rid of that fluffy fibrous tissue, the necrotic tissue. It was one of the mainstays for other attendings that I had worked with as a resident, what I saw for wound care for these kinds of wounds. And so I wanted to really kind of trial it, test it out to see if there was going to be a difference or how the Phoenix graft stood up to the Santyl. So I think we can go on to the next slide. So periodically, week to week, I was seeing initially with the Phoenix graft, remarkable changes. It initially got rid of all of the fibrous slough. It produced this nice, healthy granulation tissue, and ultimately, applying it either once a week or bi-weekly, it consistently was the only area of the entire wound of the leg that stayed healthy, granular, or at least mostly granular, and ultimately filled in depth-wise. Everywhere else where the Santa was being applied, it just was not responding as well. Ultimately, the patient, it was a little bit of a complicated course, was tapered off of his steroid and had a little bit of a prolonged delay before starting his Remicade therapy. So there was actually decrease in the healing rates and overall improvements. But again, with the Phoenix graft, it really held on, and we had this continual area of healthy tissue compared to the remainder of the wound, which just really kind of declined over a couple-week course without the systemic treatments. So by week 7, this is where he had started to kind of turn a little bit further worse. Everywhere else, he got this, everything was just fibrous slough. It smelled terrible. It looked pretty bad everywhere, except for the little bit of the remainder on the far right picture there with the green circle. That area was the only really true evidence of granular tissue in the whole leg. Then we can go on to the next slide. And then by week 10, he had kind of made a little bit of a turnaround. He had started his Remicade. The wound turned to a little bit more fibronecrotic despite the Ciancel application. And then again, the far left picture is just another example of how much better the tissue appeared overall with the percentage of granular tissue, as well as even just depth and overall appearance. So next slide. And then by week 12, again, I believe, had a second round of Remicade, and then really made a big turnaround with the Phoenix graft and had this completely granular tissue again, with decreased size and depth again, all in the most proximal portion of the wound. Elsewhere, the wound also improved, which I attribute to the Remicade therapy, but the appearance of the tissue in general, again, just didn't really match what the Phoenix graft was providing.
Great. Okay.
Thank you, Dr. Morrison. Phenomenal case. Pyoderma is always a challenging. Yeah. And what I like about what you said is that, as we're listening to that once with pyoderma is also what you give the patient, the steroids, the medicine. But when we come back, I do want to talk to you about the appearance that you saw. But now let's go ahead and introduce Dr. Reagan. Dr. Reagan is at Premier Kettering Health Network, Ohio. I'm going to tell you that I met Dr. Reagan a week ago, and I was so impressed. You're going to see some wonderful cases. And he also, what caught my attention, just like Dr. Mullane, he's interested in the cellular molecular level of wound care. And I love to change the paradigm. I love to change wounds by attacking the wound itself. And of course, that's after we deal with the whole patient. So Dr. Reagan, take it away.
Thank you. It's really an honor to be here with everybody. And these are great cases, very challenging cases. And we obviously all choose some of the same dirt. So helping each other along is most of what we like to do. I'm going to show you a couple of illustrative cases of things that we normally see day to day, not the exotic stuff, but the diabetics that are high risk, peripheral vascular disease, peripheral arterial disease, mixed disease, connective tissue diseases, anesthesia risks such as cardiac issues, and perhaps a little mix of some renal issues as well, where you're really having to calculate how far can I take this patient without doing more harm than good. And we don't usually worry about people dying from the effects of foot or ankle or leg surgery. We worry about anesthesia. So having the tools and the mechanisms to employ that are effective, but reduce the risk and maybe even the length of stay of the patient are incredibly important. And I've always been wanting to move towards synergy in our stewardship of these patients. How do we get the patient out of inflammatory state? How do we get them out of the infected state, convert them to clean, and then make them a potential candidate for limb salvage and repair? And it's an additive type of process, as all of you know. You start with simple protocols that you learn when you're a resident, and you build ever more complex problem-solving scenarios to address the challenges that rise to you. This is an interesting and very frequent type of scenario that I see. I've done dozens of these cases with exactly this protocol. And we have a open fracture of a second toe proximal interphalangeal joint with joint sepsis osteomyelitis. You can see the slide on the left. The toe is dislocated dorsally and it is fractured and infected through the joint. He's had IV antibiotics, he's been elevated, and we've been using Domborough hypertonic acetic wet dressings to encourage and consolidate drainage, reduce contagion. It's, of course, acetic, so gram negatives get knocked out. It also exfoliates passively and gently exfoliates devitalized tissue. So with that prepped, he looked a lot worse when he came in, but clearly he needed an amp of the toe. Nothing else is really going to work for this guy. And he had very limited options for anesthesia risk and everything else, including his PVD status. So an open amputation was done with a slight curvature, plantar medial. If it was the fourth or third, it would be curved plantar lateral. On the other side, it'd be curved plantar medial and a slight lazy S dorsally. This allows you to open that up, transect the metatarsal, and dissect everything forward, excising the synovium and the flexor plate. So all you have is muscle in that compartment, muscle and skin. And you take the long flexor and you cannulate the flexor canal, open that up and put a drain out through the plantar aspect of the foot, so you don't have any trapped drainage. So after irrigating that with solution and seeing everything viable, hemostasis, that's when we employ the Phoenix graft by parachuting it in, and in a diamond shape, basically pack it into the wound, anchor it with usually north, south, east, and west, some 2-0 or 4-0 monocryl to anchor it in place, and then pack the wound open, keeping that good contact with the wound interface with gel foam. So that's a passive packing. I don't like hard packings. You don't pack and wrap is what I always taught my residents. But you can use a passive soft wrapping like gel foam because it turns into a jelly. It's hypertonic, and basically you leave that in the wound, and we usually don't take these wounds down for at least 2 or 3 days. We pull the drain, we take a look, we culture the drain if we have any concerns. But at that point, we can decide then, is this patient a good candidate to go back to surgery to do a secondary repair? Or would this patient be better off being followed as an outpatient? And either becoming a better candidate for secondary repair, or can we treat this patient and heal him by secondary intention? And the secondary intention option is the best for most of these patients that are elderly, bad circulation, bad anesthesia risk, et cetera. And you can see that within 4 weeks, we usually take the graft out by the 4th week. 3 weeks, 4 weeks, we'll take some of that gel foam out, and it'll squeeze out passively by itself too. We release the sutures and peel out that residual Phoenix graft, and now we've pre-laminated our wound, and it looks beautiful. It would be a pleasure to take and do a secondary repair. It's been converted clean, and the wound surfaces are now pre-laminated for repair, but you don't have to repair it. All you have to do is stand back and let the body be the hero. And you can see that 2 weeks later, you can see it's going to be closed. The deep part is closed. There's no depth. The muscle is revascularizing the wound. And 8 weeks afterwards, this wound is healed and the patient's ambulatory. He did not have to go back to surgery. He did not have to risk all kinds of other things. And these patients are so risky, you can't even wrap them. You know, I mean, you put Kerlix on this kind of a patient, you're going to wind up with 4 ulcerations. So the dressings are simple, everything's simple. The nurses love it. And this is a good intervention for a patient that you either need to do a long transition from acute IND conversion to clean wound and repair, or you need to consider that they may have to have secondary repair. So I think this is a useful application, especially for this modality, and it's been very helpful for my patients. Get the next series, Joy. Yeah. So, and this is one that we see all too often. A new onset diabetic who's not aware that his foot is infected and goes on, blows out a joint with joint sepsis, osteomyelitis, and a big soft tissue loss, full thickness soft tissue loss. So what you're seeing in the pre-op is sinus tract into the joint and rotten tomato syndrome. And his first post-op week, you can see that it's still kind of irritated. So we go back, we keep the, and this dry gel film is what you see there, the white stuff. The gel film and the Phoenix graft are indwelling. And we'll start with some more of the hypertonic acetic wet dressing to convert that to a cleaner wound. But we leave the internal components, the Phoenix graft, intact. And you can start to see by the 4th week, he's shedded off most of the gel foam has been squeezed out of the wound. And there's no inflammatory effect in the wound borders anymore. All the gel foam is gone. And this is 8 weeks post-op, and he's just about healed. So this, I can't argue with this, you know. We did a flap closure of the plantar aspect of the wound after a week of the hypertonics, but left the dorsal part of it open. And this is his post-op after repair. So this is a fairly large deficit that we still had. Now my option was to take and do a fillet flap, pedicle flap using the 4th toe, but I didn't want to do it because I really had confidence that we could close it with the Phoenix graft. And we had muscle transposed. The intrinsic muscle transposition was done here to give us good vascular basis and bed for the healing. And you can just see how that contracted in 3 weeks and then it's closed down. Very happy with that. So I think my main concern, I typically use this after an incision and drainage. And when I'm concerned, especially that I need to establish whether I have a viable wound bed that's a good candidate or a poor candidate to return to surgery, the Phoenix makes the difference. You know, it sounds crazy, but even within 3 days of putting a gentamicin impregnated Phoenix graft in an open wound that we have done excision of bone and soft tissue with, it looks like a different wound. And then you have the option. We need to wait till this patient's revascularized. That happens all the time. I'll do an IND like this. The patient will need to go to the cath lab. They might need to spend a couple days getting him set for that. Might have to de-escalate his antiplatelet therapy before we take him back and do a repair. So in this case, you might have to wait a while. Might have to wait 2 weeks before you get it back to surgery. You've done what you can, and you're really staging the patient for success by interposing that Phoenix graft. And it's been a very tried and true mechanism for something that we commonly face. You know, these decision-making protocols get a lot less complex. We have an effective tool. Anybody have any questions?
No, that's phenomenal.
We have a lot of other cases. I mean, I've done a ton of cases with it where we did more complex repairs. But the most important stage is that confidence that you can build in getting from the dirty, ischemic, inflamed wound to the wound that's prepared for repair. Okay? And we have plenty of stem cells. We don't need to put stem cells in a wound. What we need to do is create a platform for healing by converting them to a non-inflamed state, because we know what stem cells do in an inflammatory state. They have two options. They can die, or they can make scar tissue. Sometimes scar is a safety valve, at least temporarily, but we don't prefer it. And what we like is phenotypic specific regeneration of tissue that can only happen with stem cells when you have resolved the inflammatory state and create an opportunity for stem cells to do their thing. If I think you'll all agree with that.
Mike,
And
this is a fascinating case, because the other thing I see, and it's brilliant the way you're applying this in terms of this internalization component, and then being patient in terms of the observation. But as I look at pre-op to post-op to 1 week, and then 4 weeks, with the really good resolute decrease in inflammation and decrease in the accompanying interstitial edema, you're maximizing that microcirculatory reperfusion.
Yeah.
And you can see it demonstrated in these pictures. And so it's really a disproportionate change in a short period of time with what you're accomplishing. So I'm really impressed with how you're applying this. And from talking to you last week, this is a pretty routine outcome in your practice now. Is that correct?
Yeah, it is. Yeah.
And I think, again, getting back to our passion on the cellular level, endothelial cell function is clearly better as inflammation goes down and there's that change in the proliferative phases of healing. And again, that's all based on removing rarefaction. So you're recoupling microvascular perfusion down to that 5 micron level. And there's not a lot of grafts that I have seen that have the ability to do this. And it's a great, unique application of this. So congratulations to you and your team on what you're accomplishing.
And Dr. Reagan, there's some questions coming in,
Sure.
and I do have a lot more for y'all. But if we go back to the other slide for the second ray amputation, Beth, the question for that one was, what guidelines are you using for a drain on this case?
Well, usually what we're concerned about is residual infection in the flexor canal. It's the most common scenario causing complications with any digital amputation. As a matter of fact, a lot of the digital amputations I see done do not address the problem at all. There's the gangrene of the toe is the symptom of the disease. The disease is actually the flexor infection choking off the venous return, and then a secondary wet gangrene occurring because of the outflow obstruction. So unless you go in and take out that metatarsal head, they're probably not going to get better. If you don't at least decompress the flexor canal, they're not going to get better. So that's incredibly important. And don't know if that answers the question. What was the question again?
It's well, we were talking about what guidelines would you use for a drain on cases like
for
this?
drain. Okay, so if you talk to one of my former residents, I had some of the brightest people in the world to work with. You know, you taught them a little bit and then you got out of their way. You know, they're really smart people. But if you were to say no drains, question mark, they would say no brains, because especially in closed compartments and tight structures such as we have to deal with in the foot, you have to use drains. And we prefer to use small blue vessel loops, which are solid. They're made out of silicone. They're not a two-way street. I like passive drains in particular. I will point a hemostat. I'll follow the flexor canal. You can't see the drain because we're not seeing back far enough, but I'll take it all the way, halfway down the foot to where I know there's no inflammatory signal, and past any of the retinaculum that could trap fluid, point it out to the skin, make an incision, and draw that vessel loop out. Okay, so that'll trail from the open incision here through the plantar compartments. And if I see any dorsal inflammatory changes and it looks like there's something, I won't hesitate to put one out proximal and dorsal as well. I don't like tubular drains. I don't like a two-way street that can reflux back into my wound. Okay, the decompression of these wounds is incredibly important, and especially after you do a flap. If I do a muscle transposition and a fasciocutaneous flap, I'll use 3 or 4 of these, maybe 3-inch pieces of the vessel loop drain as incision drains, and you can thread them right out through the incision and pull them in 48 hours, and it has no effect on the wound healing. You can even leave them in for a week. They're passive. They're soft enough that they don't occlude any structure. They won't put any vascular embarrassment on the tissue. They're radiopaque and they're silicone, so they're non-conductive, you know. So I really like them, and it's cheaper than the silicone incision drains, which are nice, the flat ribbon drains, which, you know, I grew up using as a resident, but they're very expensive comparatively. So the vessel loops work quite well for that. And I would always use a drain unless there's some specific reason not to. If that
and, you know, this brings up another interesting question. And, you know, I'm talking from the experience also. I want to pick your brains, but the question was to Dr. Meline about which secondary dressing did he use on that scalp wound. But I want him to answer that, but I'm going to ask the panel this, because when I treated, and we must have seen a lot of patients, I couldn't tell you that one dressing was better than the other. But Dr. Meline, you want to tell us that dressing you use on the scalp?
Well, sometimes we'll use Mepitel, and then we'll put a secondary absorptive dressing and just change on top of the Mepitel, or we'll put on Mepilex, which has its own inherent absorbency component. And then we can leave that undisturbed for a week when we bring it back for the rechecks. So we've used both with success.
Great stuff. Great stuff.
Dr. Morrison, which dressing did you use on your cases?
So mine was, we used a combination of things depending on his drainage. So most of the weeks I saw him, he was draining significantly. Not necessarily from the area of the venous graft, but everywhere else. So it was a little bit of, you know, we utilize just regular ABD pads. We use Draw-Tex. Every now and then some calcium alginate with that. And then he ultimately is, you know, a patient with not great insurance. So his dressings at home for the supplies that the nurse was doing were all very simple ABD pads, really.
And you know, Dr. Morrison, you mentioned something about the drainage, and you know, your patient's a little different, because if you talk to Dr. Meline and I, we're going to say the lymphatic was involved, and that's why you saw that drainage. But I felt like with a lot of the patients, I was chasing after the drainage. And what I noticed was that initially we saw more drainage. And I ended up having to get the company to have a scientist kind of explain that. And actually, I did a talk with the scientist the other day. Did you guys notice that? Anybody in the panel that initially they had a lot of drainage? Dr. Regan?
Drainage for what kind of case you're talking about?
With any of the, you've had a lot of experience with the product, but when you applied it, did you notice more drainage initially on your patients?
No, not really.
Okay. And initially we saw ours, but what I saw was the chronic wounds that we were seeing. It was the change in the environment creating a little bit more of a change. So we use different dressings to accommodate the drainage. So here's another question for Dr. Morrison. Did Phoenix and its pH modulation on the wound biome have a positive effect on your pyoderma case to reduce the return of slough and biofilm?
Ultimately, I think yes. I go back and forth with, you know, was it the pH factor? Was it the angiogenesis factor, or a combination of the two that ultimately improved the wound the most? I think a pyoderma wound is so different that ultimately when you think about, you know, like increased neutrophilic, you know, count in a wound, it's the increased inflammatory properties, I guess, but the decrease in the pH with the graft, I think, was very helpful in allowing for maybe a little bit more recovery and decreased chronic inflammation that I was seeing. And then in addition to the angiogenesis aspect, I think the ability for the small capillaries, you know, as we kind of talked about in the other cases, to come up to the surface of that area of wound in particular just really helped the healing in general.
Yeah, well, actually, Dr. Moline, since they're talking about biofilm and you had that, I call toy, the Moleculite device, did you see any changes in biofilm?
So in all honesty, we're working on getting this technology into our clinic. So I can't give good follow-up, and I think that would be a really great prospective study to look at biofilm modulation, which we would expect as we're decreasing the inflammatory component. But that's a study waiting to be done. Now, Frank, something you said I'm really fascinated by, that you were noticing increased drainage. I think you were talking to Jed Johnson.
And actually, they were talking to Dr. Kalin at the same time.
Yep.
And, you know, yes, Jed, what they were talking about was you are changing the pH, but the lactic acid had a component to it. So when you're attacking the wound bed itself, it produced more drainage.
It'd be interesting to do an omics study on the fluid that's coming out. You know, measure chronic wound fluid first, and studies like this have been done before, and then measure that after application and see how that, what's called proteomics components are changed. So, and then going back to just correlating that with acceleration and healing. Now, it's all obviously theoretical, because what I'm seeing with Mike's case and what I'm seeing with other cases, the posters you've done, the modulation is rapid and it's consistent, and it's really changing wound environment in a very consistent way.
Yes, thank you. Dr. Regan, Dr. Morrison earlier talked about the appearance. And as you're using this product, have you been able to see a difference in appearance in granulation tissue? Or how does it compare to other form of treatments that you've done?
Are you talking about topical wounds, open ulcers?
Ulcers, yes, sir.
Okay.
And I apologize. I know you do a lot of surgical and trauma. I don't have that.
Do a fair amount of open wounds as well. Yeah, I think the appearance does change. We use Anicept, which is hypochlorite, 0.057% hypochlorite Prep gel, which is ultra safe compared to Dakins. I'm very concerned about Dakins injuring people, and I won't use it. But this is the opposite. They've met the threshold between what works and what is safe. And what we need is something to lyse and allow exfoliation of the dead tissue, because I think drawing a lot of drainage into the wound, just from the characteristics of the wound itself, you have all that hypertonic dead tissue sitting on that wound. Of course, it's gonna draw a lot of serous fluid into the wound. So you need to get rid of that. And how you do it, we all chew the same dirt. So I didn't mean to say it was easy, but that's one trick that I've been using for quite a while, quite a number of years. I got rid of the expensive stuff that just leaves the dead stuff sitting there. And we do use intervals of the hypertonic acetic wet dressings. Those things help as far as a wound surface additive that you can use to decrease your drainage. But the biggest problem I see with drainage is actually venous and lymphatic outflow obstruction. And that can be active or passive. Passive means the patient won't elevate their legs, Active means, of course, all those things that cause lymphedema and venous stasis disease. Post-phlebitic patients, people with pelvic inflammatory conditions, they're nightmares to me. I mean, I just have a big problem with it. And what I found is that we stopped wrapping them. We started using patch dressings and stockinettes, and then the sequential compression pump sleeves, and try to actively encourage their elevation. I mean, that's the biggest thing. When you've got a patient that sits and sleeps in a chair all night, you're going to have a hard time making progress with that patient. And unfortunately, they develop the gangrenosum, and they're going to be a nightmare for anybody that does it. You finish one of those cases and you don't celebrate. You just say, okay, well, let's go on to the next. But they're tough. And when we do use the Phoenix, though, we don't put the Phoenix on until we have a clean background. And when we do, then we'll also pair up like a silicone dressing over it often, and then we'll use external to that. We will use some of the hypertonic, the osmotics, the alginates and things like that to draw off that fluid, and then we can leave the inner dressing intact and change the outer dressing. And that's one of the reasons we went to modular dressings with patches, and it could be ABD pads, several layers of stockinette, even Tubigrip, if we want some compression. But we found that it's more dynamic addressing. The other unfortunate problem is often not addressed in these patients is a lot of them are incontinent, which is why you see the infections. And it becomes a big problem because they're sitting, if they're in a ECF, they're sitting in a wheelchair all day in a diaper with the stuff draining down their leg, and so you're dressing, you put a nice Una boot on and stuff, and what you're doing is getting it saturated with everything from hair to heresy. And it becomes a real challenge, to make a break in those kinds of cases. But we find ways to do it, and there are incontinence programs out there. They're difficult to find sometimes. But when we get a patient like that, where we've identified this is a problem, enrolled in an incontinence program, what a difference. I mean, it's one of the reasons they're afraid to lay down is they know they have to get up and go to the bathroom, and they're not going to make it, and it's a tough problem.
Yeah. And,
So
and-
we've
and
got
I-
to advocate for everything that they need, you know.
You're right. And look, there's a couple more questions coming in. One of the challenges most facilities have is having a value analysis committee to get a product in.
Right.
Did you have any problems with this product? Are there any cost effectiveness, positive, anything you can share with the audience?
Myself?
Anybody can answer that?
Well, absolutely. It was a big win for the hospital systems. We had no problem getting through the value analysis committees at all. Number one, it's very reasonably priced comparatively. Number two, this product is unique in a lot of ways, but one of the best ways is there's no animal protein in this product. There's no antigen antibody potential. There's no disease transmission potential. There's no tracking obligation. Okay, so you're not going to think about a nightmare 10 years down the road with the newspaper headlines say, you know, company XYZ transmitted disease to X number of patients by way of their pig bladder swine flu graft. It's nice to not have to explain that stuff to patients and go over the risks and things like that, but it's really nice just as a risk management perspective, and I'm a defense expert, I've been one for 30 years, it's better to prevent, you know, than it is to explain. So number one issue with my patients is safety always, you know, when we take the risks that we think are worth it, but there's very little to no risk in this. And financially, the one hospital that I use, just based on changing to this product from the other products, they projected that I would save them $250,000 at one of the 4 hospitals that I operate at actively. So we only did it on one hospital. They didn't want to do all the calculations, but I don't think it's a problem for value analysis at all.
Okay, thank you. Dr. Morrison, would you like to answer the same question?
Sure. Ultimately, my hospital does not accept the product currently, so I've not been able to really utilize it other than graciously accepting some donated grafts for my patient over the last couple of weeks. But I think, you know, they're fighting a good fight to try to get it pushed through within the mainline healthcare system, and you know, hopefully it gets approved, because I agree. I think ultimately it is a way more cost-effective product and is much safer. It clearly works. So you know, the negatives are few and far between in my eyes. But so I'm, you know, holding my breath, fingers crossed. Hopefully we'll get it approved within the hospital systems around here for sure.
Okay, thank you. And Dr. Mullane, we're talking about, I don't know if you heard the question. They're asking about cost effectiveness. You know, are you having a problem getting into your hospital? Okay.
So we have a med approval process where you need a champion and you have to be able to demonstrate data, cost effectiveness, and improvement in outcomes based on peer-reviewed published literature or presentations. So this product is set up very well from the technology standpoint. There's great understanding and reasoning of why you would use this in this wound bed. And then from the data standpoint, both from a benchtop science, you know, Dr. Jed Johnson, who's out of the Ohio State and has really done a lot of great work on that, as well as other colleagues, have helped demonstrate that mechanism of action. And then the clinical aspects, I think, are very self-evident. There's some publications on that, and you, Frank, have really quite a few posters. So getting that through the med approval process takes time. It's being patient for anybody that's looking at doing that. And then it just takes diligence. But I'm very confident that we're going to get through that as a university system, you know, where things don't move at a pace that we as surgeons typically would desire. But we're going to get there, and I'm very confident in it.
There's one more question. And the question is, can this product be used successfully on a deep chronic ischial pressure injury with a trifurcating tunneling? Does anybody have experience with pressure injuries in this product?
So as part of my practice, I'm doing both hospital consults and then surgical debridements for issue tuberosity and other pressure ulcerations. So again, framing that within the scope of standard of care, you got to make sure they have a group 2 powered mattress. You got to make sure there's adequate pressure relief. Many of these patients have bowel and bladder incontinence. So you're talking about managing stool, managing urine, and these kind of things. And then managing from a nutritional standpoint. So make sure all that stuff's being done. And then in terms of good debridement, some of the most important debridements can be done in the operating room. So if you're not a surgeon, collaborating closely with a surgeon, and then making sure that you're not missing things like osteomyelitis. So MRIs, CT scans not quite as good, but making sure that you understand what's going on so you can get the right biopsies, understand what bacteria you're dealing with. So I have not used this product in a deep wound like this in the operating room yet, but I wouldn't hesitate to utilize it in a wound environment like this. A lot of those wounds right now, we're doing Variflow with hypochlorous acid. Again, my whole goal is trying to get the wound pH down. We just had a patient like this in the hospital last week with a big issue tuberosity ulceration, so stage 4 because the bone was infected. And I think this would be a good place, could be, to Mike's great points, a temporizing measure as we're getting the plastic surgeons involved and getting kind of a good game plan together. So I think there's certainly an opportunity for utilization in a wound of that nature.
Dr. Reagan, do you have any experience with pressure injuries with with tunneling?
Well, sure. You know, at the ankle level and the foot level, when we have to go in and do compartmental fascia releases, 4-compartment fascia releases, we do need to be aware that you can develop fistulas and all kinds of wound abnormalities on the downward limb of those cases. And when we see that developing, we tend to go in and clean that out, those areas out. And we'll take and make a cigar roll out of the Phoenix graft and just throw a Benel suture through it and then drag the suture from an external portal into the wound and then anchor it on the opposite side, on the outboard side of the wound. And then we release the sutures once the patient is post-op and everything looks stable. So maybe first post-op change, like you saw in my first case there, we would release that outboard suture and leave the suture intact that's on the outboard side of the actual open sinus tract. And then you can draw it a couple days at a time out towards the wound itself, the wound opening. And we've closed fistulas very successfully that way sometimes. I think that's a big issue. That's a big challenge when you're dealing with large scale wounds and things like that. Yeah, I really like hypertonic, anti-inflammatory, bactericidal grafts in these wounds to convert them from dirty to clean. We also know that the graft is miscible with antibiotic solutions. So what I'll often do at the start of an infected case is put the graft in a kidney basin with some gentamicin on it and a Raytec on top of that to keep it saturated until we're ready to use it. And then we'll deploy that into the wound and it becomes an antibiotic eluting graft. So we're doubling up on our power there, and that can make a big difference in a complicated case.
And, I've had experience with pressure injuries, and actually the first one I've ever used it on was a complicated pressure injury that had osteo. We did take him to surgery, and when I say I work with a team, and so I have 14 doctors that I work with, and we removed the necrotic bone, left it with a void or a tunnel. What I will tell you is that every patient is different, And the fear in my eyes is that you don't want the wound to close, leaving that tunnel not moving forward. So I did try the cigarette roll where you roll it up and you put it in there. But one day I decided to do something differently, and I just put it around the outside and I covered it with negative pressure. And it was amazing how it filled in. Then I used it on another pressure injury, and I was not putting the product inside of the tunnel. And there were, I would say, 2.5, 3 centimeter tunnels. They weren't very deep. And again, I had the same response where it started filling in. But I did put them with negative pressure also. So
Frank,
just to kind of change the environment.
Are
Yes,
you,
sir.
you're fenestrating the graft when you're doing that?
So, I'm glad you asked about that, because what I noticed is that if you don't apply the right dressing on top and you have too much drainage, it will float the graft off or the product, let's say. And what I started doing was I was using negative pressure to bolster it down. And when I was talking initially to Jed, he would say the product will stay there 16 to 22 days. And that when I come back 3 days later and I take the negative pressure off, he was right. It was stick and it was hard to get it off. But to answer your questions, I started fenestrating everything because I like the fluid to go through to not float the product. So yes.
And then it also allows transformation of that micro deformation of negative pressure to that granulation bed that gets that robustness in terms of generation of granulation tissue.
Right. And you bring something else interesting. I like to make confettis of everything and put it underneath negative pressure, collagen and everything else. But talking about how the product is made and the purpose of it, I didn't want to do that just yet because they electrically spun the product. The size of the diameter of the synthetic fibers are so small that the cells can attach to it. So if I broke it up and made confetti of it, I didn't feel I was going to get the same effect.
I think you would, and I think they're moving in that direction. I've discussed this with the product development engineers a couple of times, so I think you're going to see that in the future. And the standard of care with the cavities, we always used the antibiotic beads, which are calcium phosphate beads impregnated with antibiotic, and they work, but then you have to go in and get them out. They can be a real pain in the butt to find sometimes, when you get granulation tissue mixed in, it could be a real challenge. So this is an alternative to using the beads. We still use the beads when we're doing masculate technique, when we're creating a vascularized capsule for a bone transport or putting an external fixator on, but this has made things a lot more pleasant. And I agree with fenestration. I fenestrate pretty much everything. If it's surface, it's on the surface. You get better contact, and you also want to draw moisture through it. What I like about this graft is we can put the surface hypertonics, the alginates, over this and draw the moisture into them and keep that intact. And I had a couple of cases where I had large scale coverage on a heel that had gone through 3 phases of surgery, and 3 weeks. I mean, you could see the stuff as the wound healed. I've got a nice case that illustrates it too. A full thickness loss under the first metatarsal head. So we did what we usually do, which is a perineal tendon transfer to release the tightness of the perineal tendon and let the first metatarsal drift up. And debrided that wound and put the Phoenix graft on. And as the wound healed, you could see dried, it looked like epithelium, you could see the dried graft exfoliating from the wound. And the only thing that would stick to the wound was the part of the wound that was still healing. And it took, in 4 weeks, the wound was healed. So I've also had some frostbite injuries I've used it on and things like that. Similar results, you see that it's almost like an innate intelligence in the graft, that where it's not needed anymore, it flakes off, But I'm impressed, it's been seriously a big help, you know.
Well, I do want to say one more thing. And when I speak, a lot of times what I say is not every product is going to help every patient. So when we used it in our clinic, we used it for patients that we tried everything. And again, we're not saying this is going to be the answer to everything, but the one case I do want to share, and patients loved it because every time they would come in, we name them something. So this one was Hope. And Hope was facing amputation on her other leg now. 3 doctors already said she was not willing to let go of her leg. And we were saying amputation. ABI was horrible. And so we decided, why not? And Hope did heal. It took, a little longer than most people would take, but she was complicated. She had 6 wounds and they all healed. And I didn't think it was going to. So, but, with that, again, I want to reiterate, not every product is going to help every patient, but knowing how you can alter the environment is paramount. With that being said, Dr. Reagan, Dr. Mullane, Dr. Morrison, thank you so much. Beth, I'm going to turn it back to you.
Yes, thank you so much. This was such a dynamic conversation, which is exactly what we wanted to bring to everybody who was participating as attendees online. I just want to check to see if there's any last questions. There is one that actually I would like to ask each of you, and I think it was a perfect ending, Frank, where you're saying, it is very well known, especially in wound healing, tissue regeneration in healthcare, that you absolutely have to have this whole arsenal of products, because we don't know what is going to be right for that patient, for that wound at that time. And I so appreciate everything that has been shared. But one last question that I would love everyone to comment on, because it is something that we are continuing to see very consistently in the cases and certainly in conversations that we've had with each of you. But just to comment on the type of tissue or the tissue appearance at wound closure after utilizing Phoenix Wound Matrix, especially because this is a brand new technology really emerging in wound healing, and as a synthetic, how you really do see that this type of technology is supporting and how the tissue is looking, at wound closure. Frank, do you want to start? Maybe we could even just kind of go down the list of, how everyone presented.
Yes, I'll start this off. We kept very close with a lot of the patients, and a large percentage of them did heal. We did find that even the pressure injury, my first patient with pressure injury, even 2 years later, did not reopen, and he was bedbound. So, but what I noticed is, and even right before closure, what I noticed was a stronger proliferative response. I saw more, Dr. Morrison mentioned angiogenesis. I'm actually seeing this, and the integrity, and again, it's just my opinion, the integrity felt that was a little more sound. I wish somebody could do studies to test the strength of the tissue, but we were all pleased. And when we stopped the trial with certain patients, they all slowed down on the healing, and the actual patients were saying, bring me back that Phoenix. But anyway, that's my answer.
Thank you. Dr. Mullane.
And I would say it's a heavy lift to go from chronic inflammation to proliferation. And by definition, the patients coming into our wound clinic have had wounds greater than 30 days. And these are the patients that have typically been gone through many different trials and many different things. So for products that can shift the wound environment from inflammation, do that heavy lift to proliferation, where it's really organized angiogenesis. So not hypergranulation tissue that's dysregulated that ends up not being functional and contributing to epithelialization. That's the goal. And, in the few patients we've had the opportunity to trial this on, that's the kind of wound environment that we're seeing come out of utilization.
Dr. Morrison.
So ultimately with my case, obviously my patient is not healed yet, but in just comparing the overall wound base tissue as well as the healed peri wound, the new tissue, there was such a discrepancy between even just week to week after the grafts, the decreased inflammatory appearance. There's so much less peri-wound erythema, decreased swelling to the area compared to, more distally with the leg, and, overall increased granulation tissue or, just stabilized granulation tissue base. There was just this pronounced difference between the area where I was putting grafts on versus where the graft was not, despite, systemic treatments or not.
Thank you. Dr. Regan, any final comments?
Yeah, what I see as far as the tissue changes is that we have effective wound closure and closer to ideal, excellent wound strength. And we test our wound strength all the time. Our patients walk on our wounds, so the effective test is positive. And what we're seeing is that we are converting this patient from an inflammatory state and maybe a preceding infected or injured state to a non-inflammatory pro-regenerative phase. And that's something that we're always looking for. That's our ideal. And I think we see more of this with this construct. And there's no doubt about it. You saw my cases. They healed 95% to 100% edge to edge with minimal scar, with minimal cicatrix, and excellent strength. And there's no way you can kind of fake that. It's real. And once you've got a good functioning wound environment where the progenitor cells can be up regulated, and you've down-regulated all the inflammatory factors, now you have chance for success. So that's what we're asking for, and that's what we see with the Phoenix.